Hi, my name is Laura Esfeller, and I'm a patient advocate with the Kidney Cancer Association, and I'm here today with Dr. Michael Harrison from Duke, and we're going to be discussing his study. So, Dr. Harrison, please share with us a bit about your quality of life study.
Sure. So this is the Odyssey Prospective Observational Study. We named it Odyssey because we really wanted to focus on the patient journey. So it's a little bit unique in that the primary endpoint is actually around patient-reported outcomes. And so the gap that it really fills is that, and I have this in here, but in the different pivotal clinical trials, of which there are about 4 of approved therapies, they use different instruments, different patient-reported outcome instruments. So these are like things like asking about pain, are you having fatigue, other either symptoms from the cancer or side effects from the treatment. So we wanted to really focus on the patient experience, but also in the real world, because we know that clinical trial patients tend to be less sick and just kind of different overall than our real world patients. So that's the basis of the study. And what this poster is really focusing on is those patients who got systemic therapy. So kind of the commonly FDA approved 4 different regimens that are IO-based, so meaning with a PD-1 or a PD-L1 inhibitor. And so we wanted to describe their characteristics and look at their quality of life. And then I think what's a little bit unique is we had the ability to ask physicians, in addition to asking patients how they were feeling and functioning, asking physicians, why are you doing what you're doing? And then look at starting doses.
Interesting. So you were taking the patient-reported outcomes, or PRO tools, to make sure that patients were having the responses that you wanted to see, and then influencing treatment decisions, it sounds like, potentially as well.
Right. So this is a baseline analysis. So this is not reporting the longitudinal PROs, meaning patients how they're feeling and functioning over time, but this is just looking at the baseline, kind of some of the baseline characteristics. But yes, in future analyses, such as at GU ASCO, which is in San Francisco next February, we'll be looking at those kind of more longer-term patient-reported outcomes.
Fantastic. I know one of the things that patients sometimes encounter is once they're off of a trial, sometimes those PRO mechanisms aren't followed through. And so, are there any recommendations from your research that might influence, patient follow-up long-term?
That's a good question. We had the same trouble in this study, right? And is that, we don't necessarily know what happens to patients when they come off of a trial. So fortunately, these patients, what's a little bit unique about this study though is that we're not just following patients through one line of therapy. So clinical trials typically just look at a line of therapy, and then when they're off the trial, they're off the trial. These patient-reported outcomes could go across multiple lines of therapy or even no therapy. So while this is focusing on those who did receive systemic therapy, there is a cohort over 100 patients who are undergoing active surveillance, and so we're looking at their patient-reported outcomes too. But unfortunately, we haven't solved the problem of losing patients and losing their experience. And there are certainly valid reasons why patients no longer wish to be followed. It is a lot of time, and we are grateful to the patients who did agree to be followed.
Absolutely. So, final takeaway for patients and their providers in clinic from your research?
I think the final takeaways are, number one, we have some evidence now in the real world. And so just real quickly looking at the baseline characteristics, we're seeing that patients are being treated with these regimens who don't have clear cell predominant histology. So if you look at like the cabozantinib, nivolumab, lenvatinib, pembrolizumab, which are 2 common regimens, it's 56 to 65%, whereas this would have been 100% in the pivotal trials. We're seeing lower rates of patients who have nephrectomy than in the clinical trial. So, across the board, it was somewhere under 50%, whereas it was 80 or 90% in the clinical trials. This was actually mentioned in the session this morning. Other takeaways, we're seeing patients in the real world. So the way this table is organized is you have the Odyssey cohort and the comparable cohort in the phase 3, and then they're kind of color-coded by that comparison. across the board, patients in the real world in Odyssey had worse quality of life, no matter which of the 3 instruments you looked at. Some of these were not captured, like I said earlier, they're not captured across trials, but they did have worse quality of life. So, just again, underlining that patients in the real world are not the same as clinical trial patients. I think, 2 other interesting things I'll just point out. So the physicians selected reasons for systemic therapy regimens. Interestingly, it was overall survival with ipilimumab and nivolumab, which is a combination immunotherapy regimen, and it was delaying progression with the IO-TKI, the 3 other IO-TKI regimens. So a little bit interesting. We have longer-term follow-up data with ipi-nivo, so maybe that's the case. And then if you look by different regimen, you can see some other things that I won't get into. The second thing I'll just mention is if you look at the TKI starting dose, according to the regimen, what we saw was a little bit interesting. So what we're looking at is, did physicians start the treatment at the FDA-approved starting dose? For cabo-nivo, it was 100%. For len-pembro, it was only 45%. And then there was even a kind of a splay down from that with axi-pembro, it was around 88%, so still pretty good. But the disconnect seems to be there if you're starting, so these are all IO-TKI regimens. If you're starting an IO-TKI regimen to delay progression, right, we know that those outcomes are tied to dose. And so if you're not starting at the FDA-approved dose, you may be sacrificing some of that. So that's why we put, one of the kind of interesting things is there may be a disconnect between what physicians say, the reason, and what they do, which is the starting dose. And so, going back to that longer-term follow-up, we really need that longer-term follow-up to see how that impacts longer-term outcomes and to see if that's having effects on survival and other longer-term things we care about.
Do you think that maybe because there's some train of thought that TKIs don't always lead to longer overall survival or complete response like an IO does, even though that's not necessarily the case? Do you think that maybe that's why they thought it was more about delaying progression than the overall survival?
Right. So that's an interesting thought, and that's interesting you bring that up because that's what I was thinking. I mean, so people might argue that really 18 is good enough, and maybe 14 is good enough, especially if our goal is delaying progression. If you're not looking for that long-term benefit, you're just wanting to get someone through the next 3 to 6 months without impairing their quality of life. So, that could be it. But we can't really study that in the context of this trial. But it is an interesting thought.
Well, thank you so much, Dr. Harrison, for your time, and thank you for your commitment to patients' quality of life and how that impacts patient-centered care.
Yeah, thank you, Laura. Appreciate it.